Hello, welcome back. And as promised, we were going to get our good friend and colleague, Dr. Leslie Madrick, again to share with us about some information on psychedelics and ketamine. And a lot of you folks had shown interest and were requesting information on that. And as promised, I said I'm going to bring Dr. Leslie Madrick. I know last time Dr. Madrick shared with us about opiates, opiate withdrawal, what opiates is, and many of you found that information very helpful. So, hi, Leslie, welcome again.
Oh, thank you so much for having me. I really appreciate it.
Of course, it's always wonderful, and we so appreciate your time. And I know you're doing some wonderful things yourself. I love your channel, by the way. Your videos are
Thank
amazing.
you so much.
Yes, so helpful. And I love the holistic approach you have taken. And that's also indeed very helpful. So Leslie, share with our viewers here a little bit about your journey in this last year, and just give us a little introduction as to, your background and what do you do currently?
Sure. So I graduated from Philadelphia College of Osteopathic Medicine, and then I became board certified by the American Osteopathic Board of Neurology and Psychiatry. And I'm also a diplomate of the American Board of Addiction Medicine and the American Integrative Board of Holistic and Integrative Medicine. So in the last year, I've also received certification by the Integrative Psychiatric Institute, and it is an psychedelic psychotherapy program. And so I've completed that year certification, and that's where a lot of this information that I'll give you today comes from, as well as my experience with the S-ketamine treatment, which we can talk about a little bit more. So it's been really an exciting journey. A lot of people have been very interested in hearing more about it because it is so different than our other medications that we have. And it's been getting really incredible research, and a lot of people are already experiencing a lot of great benefits from it.
So Dr. Mandrick, we can begin, and I would just kind of leave this podium to you, and feel free to start with. You can go ahead and share with us about ketamine, like what it is, what it means, and how does it benefit in the field of psychiatry, or if you want to start with psychedelics. So I'm just going to leave it up to you.
Sure. Well, psychedelics really, the definition is really mind manifesting. And so it really refers to the medication category where there's mind altering experience or an out of body type experience. And there's several different psychedelics that are being studied today. As you mentioned, ketamine is one of them. That's actually been used since the 1970s for pain and anesthesia. So we know about ketamine very well, and it is actually a quite benign medication. And it's been studied for depression since the 1990s and IV ketamine since the 2000s. And there's others still that are actually in research, which have some incredible results now. Some of the others are called psilocybin, which is one of the active ingredient, psychoactive ingredient with mushrooms, different families of mushrooms. There's also MDMA, which is referred to as sometimes ecstasy, and that's actually an empathogen, so really helps with emotions, and we're seeing great results for PTSD. With the psilocybin, a lot with depression and anxiety. And so we're actually at the end stages in terms of FDA approval for both of them. They're actually kind of at the race, and I think MDMA is probably going to get there first, but some really amazing results for trauma. And we can talk about why that works a little bit later. But we do have one that actually is officially as FDA approved, which is S-ketamine. And that is a sister drug to ketamine. It's sort of the what we call the racemic, or sort of the mirror image chemical of ketamine. And so it's so closely related and works very similarly. and it's been approved since 2019. So I've had the privilege of being able to use that medication in an office-based setting and really getting some amazing results with people that have not really benefited from other types of treatment for depression in particular.
Gotcha. Okay. So if I heard you correct, Leslie, is the ketamine, is it considered under the umbrella of psychedelics, or is it like a separate, different, like
It
separate?
is.
I see. Okay. So
It's
it is a part.
considered a psychedelic, and so is the esketamine, because you do have a dissociative process that happens with it. Sometimes people can feel like they're floating. Some people can feel a sense that they're out of their body. And it's usually not an uncomfortable experience. But the interesting part about it is during the research process, they actually found, and they don't understand the mechanism of action of it, but they actually found out that the more dissociation someone has during the experience of the treatment, the greater the results. And they still have not figured out why. So we don't want to necessarily take that aspect away. I know we can talk about a little bit more about how the process actually works. And for people that this is a completely new experience, I could realize that's a little daunting, that they may want to take away that dissociative part, but actually it's important not to really add a lot of other medications like tranquilizers and things as part of the process that might kind of hinder or dampen some of the treatment experience.
Dr. Madrick, about the dissociation, I mean, if you can help our viewers understand, because when we hear the word dissociation, it's usually under the realm of something, you know, which is not a norm. Dissociation meaning that you are completely detached from your environment, you're having this out-of-body experience. So we'll help our viewers understand that. So these products, these drugs fall under this dissociative category. So how would, I mean, first of all, how do they cause that? And secondly, how does it even help with depression and trauma?
Yes, well, it's interesting. Yes, there's a lot of layers to that. So it almost may feel, I guess, if someone went to a dental appointment and they may feel like, oh, they might be a little floating above their chair, or they might visualize things that may look a little bit differently. So there may be a little alteration in their senses, but it's typically not a very frightening experience. It does hit different aspects of the brain. And it should be noted that these medicines are only given specifically under the guidance and direct supervision of the provider. So people aren't really taking these medications as they're going about their day. I know there's quite a bit in social media, some discussion about microdosing psilocybin in particular, and I wanted to make sure I made mention of that because as part of our educational experience, it is not really typically being treated that way, and the research isn't really being performed that way. So a lot of people are making up their own protocols, and yes, they're using minuscule doses. However, that's really not the way it's intended. And without the direct supervision of a provider plus a psychotherapist, it can really unravel a lot of memories. And that's really how specifically MDMA, for instance, can work so well with trauma. And I think it's a beautiful way that it does occur is because MDMA is an empathogen. It does help you emote and feel emotions very deeply. And when you take a trauma that can be a very horrifying experience, if you take that the medicine that can actually help you to relax in that moment while you can recall those memories and have loving, open feelings, that open heart space during it, then you can actually be in a safe place where you can actually be able to process those emotions, to be able to change some of your feelings about them so that they no longer have that incredible burden. And we talk about EMDR, for instance, which is another type therapy that's without the use of medication, that is actually a similar type of experience. And but you can get very rapid results even within a few treatments, that people can make great progress with very difficult memories.
That is so fascinating, because we do hear a lot about like psychedelic assisted psychotherapy. And I actually appreciate you sharing this, because you're so right. There are a lot of people out there who are definitely non-medical folks who are selling this idea of microdosing. So I think I'm so glad that you raised that point for our viewers, that these sorts of treatments are only done under extremely supervised settings and by specialized medical practitioners, medical providers with specific kinds of licenses. Because I know, like, I'm a psychiatrist, I can't give ketamine, I can't do psychedelics. So a general psychiatrist like me, we will have to get certified or do a specific kind of certification in order to be able to prescribe these medications, right?
Yes, that's true. And there's several certification programs out there right now. The Integrative Psychiatry Institute, I thought had given me a tremendous education. They are just so passionate about what they do, and they have such empathy that I really enjoyed their program. And I'm sure there's going to be more. And I think eventually there's going to be, a very standardized way of doing the treatment. But it's nice to be part of something so cutting edge. And I think it was just so, I was so grateful that it gave me the medicine aspect, which was I'm used to learning about as a psychiatrist, as a physician, but also to be trained in the psychedelic assisted psychotherapy aspect of it, which in my opinion, you really can't do one without the other. If you're really just doing the medication treatment and not really addressing it with the psychotherapy process, then you're missing 50% of the treatment, and you're really not able to process those feelings, which is the whole point of getting the medication in itself, to allow you to be in that state of awareness that you can process things in a new and different way.
Okay, great. That's, yeah, good to know that. Yeah. So let's go back to ketamine, Dr. Madrick, and talk about, like you mentioned, the S-ketamine, which is the one which is FDA approved to be used for refractory depression, meaning depression which doesn't get better with use of either two different classes of antidepressants, right?
Yes,
Oh,
yes. So it's been approved since 2019, and there's two different reasons for using it. That if you've failed, as you've said, two antidepressants with major depressive disorder, or, and I should mention at the age of 18 or above, and also major depressive disorder that may have acute suicidal ideations. So it actually has those two specific indications. I'm sure they're working on research in a lot of different aspects. And yes, ketamine in itself is used off label at this point because it's not approved by the Food and Drug Administration as of yet. However, specific for depression, it is FDA approved for pain and anesthesia. But because it's not so much yet for depression, they found it useful off label for many different reasons, not just major depressive disorder, but bipolar depression, postpartum depression, generalized anxiety, post-traumatic stress disorder, and the list goes on, obsessive compulsive disorder. And even those people that have sort of an existential crisis, that if they feel stuck in some way in their lives, that they particularly really benefit from this type of medication. If they have sort of rigid personality or rigid thought process, it can really help with opening people to new thoughts and ideas.
gotcha. Okay, great. Well, then, Leslie, take us through a patient. Like, say, for example, I'm a patient. I come into your office. I have heard about this ketamine. I tell you that, hey, doc, I used this antidepressant, that antidepressant, nothing is helping. I want ketamine. So how are you going to direct me? What am I supposed to do?
Sure. Well, certainly you may be referred by your usual physician if I'm not already your physician. And I would actually do a consultation first. I would actually do my own psychiatric evaluation to determine, to make sure, do you really have an appropriate diagnosis? What is your diagnosis? And explore some other things. Have you had a history of trauma? What is your background in terms of trials of different traditional medications? How long were those trials? Were there problems with that? Did you try any other type of treatment for depression, such as TMS, which is transcranial magnetic stimulation therapy for depression, or electroconvulsive therapy, ECT? Because many of the people that I see, actually, that's the presentation, is that they've really tried a great deal of traditional antidepressants. They've tried certainly TMS, possibly even ECT, and really feel like, oh my gosh, this is my chance for something to change, in terms of their mood. And also to get some collateral information from their usual psychiatrist or mental health provider, their therapists. Also, if they've had a medical exam, I would encourage that first, to ensure that they, for one, do not meet any exclusionary medical criteria. What are their current labs? Is their blood pressure stable? Is their pulse oximetry, which is your oxygenation in your blood system, if that is stable? So you really want to make sure that there's a level of medical stability before going into the treatment process. And really also exploring, what do people think of psychedelics? Are they fearful? Have they ever experimented with different substances when they were younger? Certainly, we'd want to know if people had any active substance use, because if anybody is potentially abusing any substances at this time, or alcohol, not really a candidate, not to say forever, but people would have to have a level of sobriety before actually entering into the treatment. So asking about that type of history as well. It's probably good to get some baseline testing too, with some scales, just to objectify some of the depression. So if you actually do that before starting, you can see your progress with the treatments as it goes on in the most objective way in different types of surveys that we use. And also making sure that people have adequate support. We want to make sure that they have support from friends, family. They are going to need a ride home because there may be some sedation involved. So they may have to, they will definitely have to have a ride home. So we'd have to ensure that there would be transportation to and from their appointments. But certainly I can take you through the actual treatment.
We were talking about the IV ketamine and the S-ketamine. Now, the S-ketamine, is that the nasal spray?
Yes, that's correct. That's the one that is FDA approved, and it never really gets in the patient's hands. Really, it's actually triple locked in the office to ensure safety of the patient, safety of other people. So we actually get it delivered from the pharmacy directly to the office. It is locked. But actually, the patient gives the medication to themselves while under direct supervision of the medical provider. So the patient sits in a nice reclining chair. We try to make it much more comfortable. It's not your typical white walls of the doctor's office, as we know. People can bring in family heirlooms. They can bring in their comfy blankets, their pillows. If there's photographs that they want to bring in of their family members, anything that represents their identity, whatever they want to feel comfortable. So the space is there, and they can get in a comfortable position. They're going to take a very slow inhale, and they're going to have an inhale into each nostril, and then there's a break for 15 minutes. And depending on the doses, there's 2 separate doses for S-ketamine. One is 56 milligrams, and one is more of a therapeutic dose, which is the 84 milligram. Sometimes 56 is used if someone's particularly sensitive or just starting, usually. And after those 15 minutes, they would have, if they're going to get the 56 milligram, they'll have 2 more sprays. If they're going into the 84, they're going to have a break again and do in 15 and in 15 minutes, they're going to have another spray. You can actually even give them, once the person gets really comfortable with the process, usually 5 minutes in between is sufficient. So really that actual process is going to get a lot faster. And within 15 minutes, they can have all 3 sets of 2 of their sprays. So it's a very easy process. They can feel the medicine coming on fairly quickly. And then sometimes people may have a little sensation of feeling a little maybe woozy, a little off balance, a little maybe a little bit of dizziness, but it's very rare. Some people can have a little nausea, but it's actually very easy to actually manage nausea in advance with some medications. You can also use things to kind of help with blood pressure if people are feeling a little anxious. I would really refrain from your benzodiazepine traditional tranquilizers, but using some blood pressure medicines and things that can help stabilize blood pressure and also just help people through the process of some of their anxiety. But most of the time, people tolerate very well. It's actually rare and unusual for people to have any unusual symptoms. And your blood pressure and your pulse ox is actually monitored right before you start the treatment, in the middle of the treatment, and right after. So if people are having any side effects, typically they're only during the treatment and at maximum about 4 hours. So it's very different than having a side effect from an antidepressant medicine that you might experience nausea 24 hours a day. Once the medicine, which is very short acting, only about 45 minutes to possibly 2 hours, that person will actually have most of their symptoms resolved by the time they're walking out the door. And they might go home and sleep a little bit more. They may feel a little sleepy or a little off balance, but that's why we have people transporting them. So during the experience, I always like to take some notes because some people may have some interesting awarenesses that may occur. So if people have any thoughts, I would want to write that down so that that's something that we can talk about in another session, a separate therapy session. But most of the time during the process, the patient can really just experience this by themselves so that they can come to their own conclusions about things without me putting words in their mouth. But also, while you're in their reclining chair, you may be wearing a blindfold, a cover for your eyes, which I actually recommend, and earphones with music. And usually the music does not have lyrics. It's usually something that's not culturally related, so it could be very neutral, so that it can really help people to go inward into the experience without all the extraneous environmental factors and really just tune into what's actually happening. And it's a very different experience than saying, for instance, the set and the setting are just so important. The patient's mindset and their environment, it's so much different than someone taking something recreationally at a big music festival where there's all this stimuli going on, and it's not like that at all, which some people may think, it's the same kind of experience that people may have. And I'm just there to kind of guide people, encourage people. Sometimes with patients' consent, I would actually even offer a hand, or we can talk about it in advance. There's actually a technique called therapeutic touch, which of course psychiatrists, as we know, we're very hands-off, we're no touching, but we actually have quite a bit of a conversation about it beforehand, that there is something called therapeutic touch used in this instance, that if people feel fearful or they need a little bit more support, we would ask in advance, would you like a handheld? Would you like me to touch your arm or your shoulder? And that it's never inappropriate or sexual in nature, that it's only in the context of what someone wants. And then if they want you to stop touching them, then we have nonverbal cues. Would they put their hand out so that you would know, okay, no more touching until you ask? Maybe they'd put out a hand if they want you to touch their hand. So it's a little different in that context of the experience too. If people need breaks, like say a bathroom break or things like that, of course, we would walk people in to ensure that they're feeling steady. But most of the time we try to plan for that in advance so they can have a good experience during the process.
Okay, wow. So basically very supervised, very closely monitored, and a provider is there with them pretty much all the time. Now, how long does one session last approximately?
2 hours or longer if a person needs more time. If someone just metabolizes the medicine a little more slowly, which it is really fast acting and really most of it's out of your system by the time you leave. But if people need a little bit more time because they're feeling a little drowsy or a little unsteady, they don't leave until they feel really certain and the provider feels certain that they're stable enough to go home with that loved one. However, the minimum time that they are in the chair would be a 2-hour session. That there's also with Spravato in particular, there's a very specific protocol that the person would be in the chair for sessions twice a week for the first 4 weeks, and then once a week for the next 4 weeks. The third month, it varies from individual to individual. You can do another weekly after that, or you can start alternating every other week. And I've had certain people that have done so well that they actually continued. And even after those typical 16 sessions, maybe doing some booster treatments along the way. And I should also mention that esketamine is actually really intended to be an adjunctive medicine, that it can be, and it's very safely used with your traditional antidepressants. So if people are using an antidepressant or any other booster medications, they don't have to go off their medication, excuse me, in order to actually start this treatment, which is another lovely thing about it.
I was actually going to ask you that because my impression was that before they go for the treatment, they have to maybe go off of their antidepressant. So that's not the case. So they stay on whatever they are. And then this is an adjunct, just an additional treatment that they have.
There are just a few selected medications, and it'll be interesting to tell you which ones they are. Well, for one, there is something called lamotrigine, and that's an anticonvulsant. And because it actually hits glutamate receptors, which that's really what ketamine in particular works on. It works on glutamate and helps with neuroplasticity and new neuronal formation. So because it works on that same system, there may be some competition there. So we usually tell people, if at all, if they can find an alternative to that medication, it might be better served that way to either taper it down or maybe try changing the timing of it if it's possible. But ideally, if they didn't have to use it during the treatment, then there's been no interference. The other big one, which is probably a little bit more frequently used, are the benzodiazepines. So in a perfect world, we can say, oh, let's just taper everyone off their benzodiazepines, which are things like alprazolam or clonazepam, diazepam, lorazepam, that family of your traditional tranquilizers. And we all know that if people are suffering from depression, many are also suffering from anxiety. Many have maybe panic disorders or OCD or trauma history, insomnia. So there's many uses for it, but because it's more of an inhibitory type medicine, it and ketamine is supposed to lift thoughts and memories, then that once again they're kind of working against each other. So if at all they can try to taper down, if they can dose maybe at different times, maybe only at night or not right before a treatment, and especially not during treatment. I would really use that as a last resort. If somebody is having a particularly difficult session, which would be highly unusual, I would say that would be the last resort. But if there's other methods, I had someone that got a little panicky. He had a little incident of some difficulty at his apartment before he came to the session, and it started playing on his mind during the session. And with just some deep breathing techniques, we walked through it. He didn't need any additional medication at all. And within a couple minutes, he was fine again. So it's very unusual that you will need that. The third one is actually cannabis. So we know that there's quite a bit of medical marijuana being used. I know in our state, the state of New Jersey, and several other states in the United States, that there's actually quite a bit of recreational use as well, which is actually legal in several states. So because there is so much use, we really have to have a sit-down conversation ahead of time and really just discuss that, you know, if this could all be avoided, the treatments are only for a few months at a time, and then most people are done after that. If we could avoid it or use some alternatives and try our best to avoid that and start the weaning process even before starting the esketamine treatments, then that would be the ideal situation. The nausea aspect of things is actually an interesting concept because yes, probably some nausea is one of the most common things. And I can easily tell people, oh, let's use an anti-nausea medicine right before the treatment. You won't have any problems. But traditionally with psychedelics, with the indigenous populations of the world, purging is actually part of the therapeutic process. It's considered to be cathartic. And some people have this emotional catharsis, a physical catharsis with purging and vomiting. And I know some people have quite an aversion to vomiting. And if you talk about that being part of the treatment, then many people might be dissuaded against doing it. However, it's okay to have that conversation too. Is that maybe how do people feel about it? Do they want to have this full experience? Certainly, it could be easily supported if people were comfortable with a nausea and vomiting process, but some people feel like it's actually quite therapeutic. So it's really up to the patient in terms of what they feel most comfortable, but it doesn't necessarily have to be medicated away.
Wow, that is a very interesting concept, you know. So basically, because I think I have watched a couple of videos with indigenous people, you know, using purging as a method of catharsis and getting those emotions out and giving them a sense of relief during the psychedelic. So I didn't actually know that even in the when you're doing it as a procedure, that even that time, that's something that's talked about with patients, that hey, you know, and I'm sure you guys must have specific, like a vomiting bag or something.
We do. That's the case. I mean, sometimes that would be, if people really had an aversion to it, I wouldn't even let it go that far. We could actually dose an anti-nausea medicine beforehand, and everyone feels quite comfortable and has no problems with any queasiness or anything during the process. So that can be easily controlled. And that probably the majority of people would probably prefer it that way. That can be easily controlled. There is typically an elevation in blood pressure during the ketamine process. It's a very safe elevation and it's a very short time frame. So really, usually at the peak of treatment, somewhere around 45 minutes to an hour, you will see people's blood pressure elevate. By the time the treatment ends within that 2-hour process, they're almost always, if not at baseline, very close to it. So that's already resolved. And I typically never have to dose anybody with any medication for blood pressure during the treatment. But of course, to make sure people's hypertension is monitored and adequately treated before the process, if that's a concern.
You guys. So basically, a couple of things to like takeaways again. One is that you can be on your antidepressant if you're on it. You can continue it and get esketamine. And second, medications like anticonvulsants like lamotrigine or Depakote and benzodiazepines sort of counteract. You usually try to tell clients either not to take them or to minimize them, and definitely not take them close to the treatment when they come into your office. So I guess that's important. And of course, the cannabis, marijuana. So that probably just to avoid that during their treatment. Yeah. Now, Leslie, What about the financial aspect of it? Do most of the insurance cover it, or are there people who, their insurance doesn't?
Yes, well, the wonderful thing is because the esketamine in particular is FDA approved, it is covered by insurances. So we've had patients have complete coverage, including even Medicaid for those that may have special financial assistance. So it's actually was 100% covered. It is covered by most Medicare programs, and it is covered by many of the private insurances. Now, some people, and you would see if someone did a web search on ketamine, for instance, even though it's off label, it's actually pretty prominently used, especially throughout the United States and in several other countries as well, especially in Europe. Then I would say that yes, it's used off label. However, it's readily available, but because it's not FDA approved, it is out of pocket and it can get quite expensive. It really depends on the method of it. Ketamine has some lozenges that go under the tongue or wafers that go under the tongue. There's also intramuscular injection in the arm, and then there's IV. So there's a number of different methods. IV tends to be the most expensive. That can cost even in the thousands for treatment. But it is highly effective, and possibly people may only use 6 treatments. The benefits of it is it may only be 6 treatments, and you can modulate the dose even as you're going through the treatment to tailor it to your own needs, which is an art in itself. And of course, only people that are experienced with it will treat with that. Something like, say, sublingual ketamine, which is under the tongue, or the wafers, they tend to be less expensive, and possibly treatments may be more in the hundreds, maybe a few $100s or so. And that could be just for many people, it's easier to tolerate in some cases, and easy to treat with it, and less expensive, but still get a lot of good benefits from it.
And the wafer form that you said, and the sublingual, is that also done in the outpatient settings, or you kind of prescribe them take home?
Well, it's interesting that you say that, because there were many different companies that started ketamine treatment right prior to the pandemic. And then all of a sudden we had the lockdown, and a lot of the companies had to get creative and put their ideas together, excuse me, and they changed their protocols. And actually, many people get their medication mailed to the house. They're still observed while they're taking the medicine on video, and they're monitored throughout the process by video. And then they also go through separate psychotherapy sessions. So I guess the beauty of that is that there's a little bit more flexibility to it, where you can actually have your treatment from home, whereas with the IV, you would need to be in that treatment setting in order in person to do that.
So as far as the IV, meaning the intravenous ketamine, you don't need to be in the OR, like operating room or anything. You can do it in the outpatient clinic, like your
right. Yes,
inhaler.
In a comfortable office setting. Yes.
Okay. And if I heard you correct, you said that IV is way more potent, less sessions are needed, way more effective than the nasal form, right?
Yes, that's true. Right now, you need about 16 treatments for the esketamine, which is that nasal formulation. The oral ones, all of the ketamines are typically 6 treatments on is the average. Yes.
How would you pick for someone nasal spray as opposed to the intravenous? Like, is there a kind of a protocol for the ones you go straight with IV ketamine? Like, say, for example, someone with acute suicidal thoughts.
You can still get quite a bit, even though in comparison, you're saying 16 treatments versus 6. You can still get some really rapid results with the esketamine. I've had patients, even between the first and the second treatment, even say to me that, I feel a bit of a weight off my shoulders, or I feel more motivation to do things. I started having an interest in things I haven't done long ago, or even chronic suicidal thoughts, maybe not thoughts that they were going to act on immediately or had intent to act on, but just chronic thoughts of just not wanting to live anymore and feelings of hopelessness. They actually even start to pick up rather quickly. So even though there's more treatment sessions, I could say that you're still going to get some pretty rapid results. So in my opinion, if something is already FDA approved, and maybe others would think differently, I would say that maybe starting with the esketamine treatment, especially since it's covered by insurance, the studies have been proven that this is a good method, it's a safe method, and certainly I would think that anything off label is really to use if you've exhausted other avenues first. Not to say that one is better than the other, but it's going to be a little bit more of a financial commitment, and also, you know, still the research hasn't been completed. So if you're doing anything alternative, so to speak, then I would say, you know, use that as the last resort.
Gotcha. So now, in your experience, these clients with treatment refractory depression, you gave the ketamine. What percent of people do get better or do show a clinically significant response?
They are actually saying that sometimes is up to 30 to even 75% can get really good results. Of course, everyone is on a case-by-case basis, but I would see that it's amazing to me because you're taking a population of people that are already treatment resistant. So these are not people that are taking this medicine for depression because this is their first time in treatment. Most of these people have exhausted all their other trials and did not get the treatment benefit that they were expecting. And so if you're taking that population and still seeing such dramatic results, I have to say that just with 10 people as an example of people that I can recall, not a single person had any that didn't say that they had some improvement in their symptoms. So, but I would say, you know, documentation shows that even about 75% or more can even get that improvement. And I believe it just because statistically, I've actually had quite a few patients that have also had the ketamine IV treatment and, you know, had incredible results with that as well.
So basically, I mean, even if it's 30%, but for someone struggling with depression and suicidality, I think even that 30% is a lot.
Absolutely. Absolutely. And even if there's such a struggle with depression, you know, they say it's the #1 disability in the whole world right now. And, you know, we know statistically we've had what they called different trials, the STAR*D trial. That was something that psychiatrists are very familiar with and treatment providers. And what it talked about was if people actually tried and failed just 2 antidepressants, their response was only about 1 in 3. You know, 30% of the people are going to get better with the traditional ones. Every time they try another medicine, those statistics can go down, down, down. So that's, you know, 1 in 3 people, you know, that's pretty significant to not get the type of benefit that they would be expecting. So, yeah.
It's pretty good, yeah. Share with us a little bit about the side effects. I know you mentioned a little which happens inside the clinic, like the blood pressure, increased blood pressure, nausea you mentioned, or sometimes, I don't know if you said too much of a dissociation, but what are some of the other common side effects both in clinic and what do they expect after they go back home?
Well, probably the initial is more some nausea and some sedation. Some people can feel a little off balance and feel a little unsteady on their feet or a little dizziness. And most of that, of course, as I said, wears off in about 4 hours or so, if not sooner. Some people may have some visual effects or maybe some cognitive, like thought process effects that can be affected, or even some bladder spasms, but that's very rare. So I usually use that as part of my rule out protocol. If people have some bladder issues to begin with, that they might not be the best candidate for that therapy. But even so, it's a very rare occurrence that people would have any bladder issues with it. Only people typically that have had bladder spasms prior to the treatment.
So basically, comparing to the other conventional antidepressants, it seems like the side effect profile is pretty low.
And minimal, it's short-lived. And that's the other nice part about it is, it's not going to last for very long. But actually, yes, especially because I like to treat the nausea in advance and we monitor the blood pressure closely, that it's a relatively easy process that people can easily even talk through. Once people are gradually coming out of the medicine, can have nice conversations with people. And even if they're in that experience, it's a great time to take those notes so that it's interesting to see what kind of thoughts come up. For this treatment can be so life-changing for them. Sometimes it could be the most significant experience of their lives. That's how profound it can be for people at times. And suddenly they may have changes in their lives, thinking, well, maybe I don't want to be married to this person anymore. Maybe I don't want to be in this career anymore. Sometimes they have changed thoughts about their identities and who they are and their thoughts. Many people can have some very mystical experiences and, this sense of unity. And I think that's why the psychotherapy aspect is just so important following the treatment, because you really want to do that a couple of days after, once people can process things and take some notes and journal and rest. But people can come to some very different conclusions about their lives, and you really need that support to have that safe landing back into your real life. That if you have this transcendental experience and your whole life just, you have this awakening, then all of a sudden you really need people to support you along the way of just getting through your day-to-day process. And what do you do with this new information? How do you incorporate that into your life? How do you safely make changes? And it's often because people get such a quick response that it's human nature to people want to like jump in and change their lives immediately. And we completely discourage that, because yes, you have these awakened thoughts, and yes, you may want to make changes, but you want to do those gradually, and you want to process why you're making these changes and really make some certain ideas about what you want for several months at least, before making big changes like I'm going to quit my job or certainly you don't want that. But it is interesting how people will say, like, I never came to me before, it never seemed so obvious to me before this experience. So
I think it's that aspect of the psychedelics or ketamine that fascinates me, because so you have this procedure, and it's not that you're just kind of getting rid of your depression, but what you just mentioned about this experience, this awakening, like something just kind of strikes them about their life that could be either exaggerating their depression or even leading to depression. And then all of a sudden they get this awareness. And again, this is also very fascinating that they get the awareness, but you say, hey, wait a minute, don't jump don't jump into doing this, because that's going to be the purpose of the treatment. And now, Leslie, that kind of just leads me to this curiosity. So that people do come and they have this life-changing experience. Have you had clients, who kind of just come to you, not really to get rid of the depression, but just to get that little period of relief, or this little euphoria, or just that dissociation that they feel, which feels so good to them? which what I'm talking about is because I'm not sure it can have addictive properties, but do you have clients who just kind of come there just to get that little bit of that high or,
Right. And that's a good question because I think, when we're talking about these controlled medications, that should be a concern. And it is a concern to a lot of people that is this going to be another substance of abuse that people are going to look towards? And there is what we call a SAMHSA survey that the physicians use every year. And they actually look at statistics every year of people in the United States and otherwise and the demographics of what people are using and what percentages. And fortunately, at this point in time, the psychedelics are still the lowest on the list for substances of abuse, probably because we know that some things are much more highly addictive than others, even though all controlled medications are prone to having abuse potential. There are some that have much greater abuse potential than others. So fortunately, that's low on the list. And that's why we want to ensure that it doesn't get in the hands of a person necessarily through that esketamine process, that, we're keeping it locked, we're holding it until the person is being monitored. However, that's why we want to make sure people have a long period of sobriety if they do have substance issues, if they do, or even if they never had before. We want to have very close monitoring and really have this regular conversation as you're seeing people very regularly to ensure that they're not getting this from any euphoric aspect, and to really ensure that there's a real diagnosis there in advance too, that people do legitimately have major depressive disorder and you know what you're treating in advance. But definitely there's a lot of caution being used to ensure. Of course, I believe if it ever did get to that point, then that would certainly have to be addressed. And even though maybe somebody might have seemed like a good candidate initially, then it's always a risk and benefit ratio of, is this continuing this treatment, is that really to the best benefit of that person?
Right. So basically, these are the questions and concerns that experts have already had, and they're keeping an eye and monitoring things closely. That's good to know. Then about contraindications. I mean, do you have clients who, you feel that this cannot be absolutely used, whether medical conditions or psychiatric conditions?
Well, I would also say in terms of mental health, you would really first look at, does anyone have any current psychotic symptoms? And by psychotic meaning, do people have any auditory hallucinations, any unusual thought processes, any unusual beliefs? Do people have any acute mania, meaning at this time, do they have any racing thoughts or periods of expansive mood, not needing to sleep, feeling on top of the world, being very impulsive, potentially dangerous? We would not want people in these two states because the medicine in itself creates that dissociation. And if there's not a good touch of reality at that period in time, not to say that it should never be used in these patients, but it would have to be very monitored. Same thing with people with maybe severe personality disorders. If there's certain people that have difficulty with boundaries because you're in close relationship with these patients, you're seeing them very regularly, there might be therapeutic touch being used. Without being able to have those appropriate boundaries, there might be some people that may not be appropriate at that period of time. Same thing with severe trauma. Now, trauma is a great thing to treat. Even people with substance use, they've said people have been able to maintain their sobriety with these things, but you want a certain level of stability prior to going into these treatments, whether that's trauma, whether that's substance use. When it comes to medical, it's really a case-by-case basis, but if people have any brain lesions, tumors of any kind, cysts, if there's any severe cardiac heart conditions such as maybe an arrhythmia, that they have an abnormal heart rate that may not be appropriate if people have a severe lung condition, glaucoma, meaning that they have high pressure in their eyes. If people are pregnant, that's a definite contraindication. We do not do this treatment while people are pregnant, or breastfeeding for that matter. Although there's been questions about that, because it is safe, but we defer against doing that. And certainly severe sleep apnea, severe headaches, but I'm talking about levels of severity. Many of these things, if they could be managed and controlled, there really are some relative contraindications that most people really can be cleared as long as they're monitored very closely by their physician. And then, as I had said before about the bladder spasms, if there's those bladder conditions in advance, then maybe that person may not be a good candidate. But it all is, once again, how severe is the depression, and how well can we manage the medical symptoms to make that happen.
Oh, this is so important to know. And you mentioned about like personality disorders, or like malingerers, someone faking an illness and wanting it for addictive properties. I think those are extremely important to know. And as you said, the provider works very closely with them. So, they probably get an idea that what's going on, whether this is real or not. Yeah. Leslie, we know that antidepressants have the tendency to cause mania, very rarely, but there is a good percent. Is it the same thing for ketamine or other psychedelics?
That's a great question. Yeah, there is concern about that, and it is being monitored in the research, but there have been very low to almost no switches of people having this type of treatment for mania. I can say that definitely there's a very individual experience with the esketamine, and I imagine with the ketamine as well. But seeing the esketamine firsthand, there are some people that do get stimulated in itself from the medicine, and then there's a very select group that does get sedated. So it can really go in either direction, although it's still very short-lived, meaning, several hours after that treatment, then that stops. But there's been no continuation of any like significant hypomania or mania at treatments that have had to be stopped.
Joking. Again, important to know. Yeah, I think lastly, I know you mentioned briefly about trauma, because guess what? Like on the social media, and we have had a lot of trauma experts recently. Like I was reading watch some videos on Dr. Gabor Mate, who is like one of the, the gurus of the trauma, and has done amazing trauma work. And he is so much raising awareness about psychedelic assisted psychotherapy for trauma, and has found to be extremely beneficial. Have you had any experience with that, or share with our viewers about, how does the future look like for psychedelic assisted trauma, and how exactly, I know you shared it a little bit, but how would it help someone with childhood trauma, or any kind of severe trauma they have experienced in their life?
It really is a matter of being able to process those thoughts in a safe and comfortable environment. So I think, yes, it's a physically comfortable environment, but also getting people comfortable in that therapeutic environment, developing that therapeutic alliance from the biological standpoint, because it is helping the brain branch off and make new connections. As I said, like chemically, it hits that glutamate, which is very different than the traditional antidepressants. So basically, it allows us to really change. It allows our brains to change. It allows our thoughts to change, what we call neuroplasticity. And I think that it's really a combination of all of it, and really just being able to process those memories and those thoughts outside of it in that psychotherapy session, and integrate those thoughts and changes into your life in a practical day-to-day experience, that really helps. So it's really a number of things. And I think it's great if you can really work as a team. Certainly you may have different styles of the way this is being done. You might have the referring psychiatrist, the referring therapist, then you're working with them. You may be in collaboration with them. There might be actually even a separate integration therapist aside from you that someone might be working with, or they may be working with a family therapist or a couples therapy. So you can really, there's also in many places, which I think is a great idea, to have actually group processing too. So there's many places where people can actually process in groups. Everyone that's in the group is also participating in their own psychedelic treatment. So they're able to process their thoughts in a similar way. But really just working as a team and having a multi-dimensional approach to trauma, that it may not be just one thing. Maybe the psychedelic is one piece to it that enables people to remember, that enables people to not be in that state of fear. And I think that's why it's so beautiful, is that's why trauma is so difficult to treat, because the feelings and the memories become so intense that people have to stop at a certain point, and they can't go on to completely process the experience of what happened because it's so terrifying. And if people can be in that heart space of not being in fear, then there's nothing holding them back from recalling a memory that doesn't have that same strong negative emotion attached to it. And it can really have some miraculous results. So, but there may be multiple ways that people are addressing what comes up in the session. Maybe they might be doing breath work. Maybe they'll be doing traditional psychotherapy. Maybe they may benefit from EMDR therapy, as we talked about, or CBT, cognitive behavioral therapy. So I think there's multiple ways to approach it, but just by putting someone in that state is where the real magic happens.
Yeah, I just really love how you put it through. You mentioned about this taking off the emotion from the memory, because that's why trauma is so disturbing and so incapacitating, is because you have a memory and there are these strong emotions of anger and fear and anxiety, which just renders a person so disabled to even express and builds that anxiety within them. And as you said, that fear. So taking them off, dissecting them out, just gives them that safe space to process those memories. So that's so amazing. And I love how you said it's not just, I know that this is like a breakthrough, because this could be the psychedelic assisted psychotherapy, could be that pinnacle, but it's not just it. There's a lot of other work, lot of other modalities that go into, and a lot of other practitioners, not just one person who can help you with that. I think that is really fascinating, and probably what makes it like so prone to doing more research, and hopefully, at some point we can know more about it, and it'll be more accessible to even common people.
Absolutely. And it's really taking off, and it's so exciting. And actually, you brought up Dr. Mate, and he was actually one of our professors. So we really had the thrill of getting lectures with him, and he's just amazing. And just having his wisdom and treating with trauma and his experiences with psychedelics, and it's just great to have him as part of the education process.
Absolutely. It always makes me happy that psychiatry isn't like how it was a decade ago, where we were just stuck in certain fields, but now it has just grown so much, and new research and new practices have been integrated. But this is great. Leslie, this was amazing. Thank you so much for enlightening us and sharing your knowledge, and educating people about what it is, because people often ask, like, where can I get ketamine? So this was extremely beneficial. Is there something else on these lines that you would like to share with our viewers?
I just think we're at the tip of the iceberg right now. I think it's just really going to explode as more people have the opportunity to get this treatment, as the others become FDA approved. So we have ketamine, we have psilocybin coming, we have MDMA. They all have their own benefits, and they all have incredible rapid results. And it's just nice to finally have tools. You know, we're the one specialty in psychiatry that really, our traditional medicines are excellent and they treat a wide variety of people. However, we haven't had changes really in our treatments in the last 25 years or so. And it's just great to have, not everybody experiences the same thing the same way. Not everyone benefits from things. Everybody's body chemistry is different. And it's just wonderful to have options for people. And I think it's just you're going to hear more and more, and we're going to have more and more information. And I'm thrilled to be part of the learning process in the beginning here. And I'm sure there's much more that I'll learn over time. And if people feel the need to reach out, if there's more specific questions, I'm always happy to answer them. You know, you're welcome to, you know, refer any questions to me. And I'm sure many things come up. And I'm just very thrilled for you to give me the opportunity to talk about it, because I get so excited about it, and I always love working with you. So it's just wonderful. Thank you.
It's always a pleasure, and I hope to continue our, not just the friendship, but this relationship that we have now developed of educating people through social media. And I would request our viewers to please check Dr. Leslie Madrak's YouTube channel. And Leslie, is it at Leslie? Is it at
Yes.
Leslie Madrak? All right.
And if you plug in Dr. Leslie Madrak, they will find me.
I'll put a link of your YouTube channel and of your other social media sites, because I know you do have amazing information for folks to share. So again, thank you so much. And we hope to talk soon.